prehabs and my crowns and my fillings. And then at Untethered, we speak more about sleeping and breathing and joint issues and tongue ties and myofunctional therapy, and have those bigger conversations.
With a goodly number of ear, nose, and throat doctors in the Milwaukee area, and I've worked with a lot of them. Uh, why did you feel you needed to throw your hat in the ring and get involved with this kind of surgery treatment?
I had
And don't be
seen it.
humble, okay?
I had seen it done several times, and I recognized that there was a lot of misunderstanding with the anatomy of the tongue. And we weren't taught very much about it in dental school. And the more I spoke with my physician colleagues, I realized that there wasn't a lot of time spent in medical school as well. So the tongue ties that were being diagnosed were the very obviously restricted tongues with a tongue to tip restricted fascia. But as I learned more about it, it was much more about the tongue function and elevation, as opposed to being able to stick the tongue out, and learn more about the submucosal connection. And I started to see that tether, or that the tongue tie, or the frenum, actually more as a sheet of fascia that dissects the tongue, as opposed to just a string in the anterior. So as I learned more and more about that, I got training in how to do it fully, and really enjoyed doing it. And since I saw so many of them in my dental practice, and I'm comfortable with surgical procedures, I decided to offer it as a service for my patients.
Excellent. This month, and I just read this the other day, Harvard University made a kind of a blanket statement saying, we are messing up. We are graduating some of the finest physicians in the nation. However, we're graduating doctors who know very little to anything about sleep medicine. And they stated they receive about 2 hours of education and 4 years of medical school. Did you have any training you went to Marquette? Am I correct on that?
Yes, I did.
Did you have any training, formal training at Marquette, or exposure to dental for sleep medicine at Marquette?
No, not at all.
Really? Well,
There may have been a lunch and learn, an optional lunch and learn about mandibular advancement devices, but that's a very big might. I don't actually remember attending one.
okay.
And I left not knowing very much about not only sleep and breathing, but the joints as well, and have gotten a lot of my education post grad school.
Sounds familiar. Okay, well, I'm going to get my face off this thing. That's not going to bring any business in, so to speak. And I'm going to let you present this wonderful presentation, and then afterwards we'll have some Q&A if anyone's still around. Okay?
Okay, sounds great.
You bet.
My intro is in the presentation itself. I'm just so excited and happy to be included in this topic. I'm a firm believer in medical professionals, dentists, physicians, physical therapists, occupational therapists really needing to be educated and open to understanding function more than we are. So much of what we are trained to do is to fix problems, or the what, as I call it. But if we can dive deeper and really understand the why, and understand how we function contributes, or how we dysfunction actually contributes to so many of our issues, I think we would do our patients a huge service. So I'll let my intro speak for itself during the presentation, and I'll be here to answer questions at the end.
Thank you, Dr. Graham. Here we go.
I'm a general dentist, and I practice on the east side of Milwaukee. And I've been asked to present on tongue ties from the airway perspective, and what tongue ties, and more specifically tongue function, can have, what kind of impact that can have on growth and development that leads to airway problems. First of all, I want to just say that I don't have any conflicts of interest to disclose. And this presentation is done in accordance with the ACCME, along with the American Academy of Sleep Medicine and the Wisconsin Sleep Society. So a little bit about myself. Like I said, I'm a general dentist. I'm a lifelong learner and a self-proclaimed CE junkie. I can't quite get enough of continuing education. I fell into airway-aware dentistry about 5 years ago, and continue to learn every single day how we can impact patients' airway, for the good or the bad, with what we do in the mouth. These are my little tongue-tied airway babies, and they have been very motivational to my passion to keep learning. Like many people that have fallen into this realm of dentistry and healthcare, my journey began personally and developed a passion for it so that I could help patients as well as my own family. So how a general cosmetic dentist kind of came to care about tongue ties was that I started noticing the same presentation in patients over and over again. And I realized that a lot of what I do restoratively is avoidable if we can get to the why before it becomes a problem. And that's true of obstructive sleep apnea and sleep disordered breathing as well. But I came from it from the perspective of restoring teeth. So I recognized these patients in myself and then in my kids, and I kept asking why. I realized that the interventions can change a patient's trajectory. So as soon as we realize there's a problem, we can redirect growth or redirect that path and get them out of their own way, which is really how I think that we should be focused on providing healthcare, not having to provide healthcare. So while I have a general dental practice, I also have a kind of a subspecialty practice where I deal with tongue ties specifically. So patients come to see me to evaluate if their tongue is restricted, and I help establish an interdisciplinary team that's necessary to get the function optimized, and if necessary, do tongue tie releases. And I treat adults, I treat children, and I treat brand new little babies to help with the breastfeeding journey, which also impacts growth and development of the face. So over the last several years, I've spent hundreds of hours and traveled thousands of miles across the country, spending tens of thousands of dollars to learn all about this. And like I said, I continue to learn every day. I'm so grateful for the people that I've met. A lot of my mentors have become dear friends of mine, and they inspire me to help continue connecting the dots for my patients. We have such an important role as gatekeepers to the whole body that it's a really cool, unique scenario that we have as dentists to be able to make such impact. So my presentation today, the objectives of it are to hopefully connect some dots for you. I want to discuss the tongue and how its function impacts growth, breathing, and sleep, as well as how its dysfunction can be due to restriction in its movement. One of my most impactful mentors, Dr. Sarush Zaghi, starts his lectures with a very cool quote from Dave Sackett, who's considered to be the father of evidence-based medicine. That quote is that half of what you'll learn in medical school will be shown to be either dead wrong or out of date within 5 years of your graduation. The trouble is that nobody can tell you which half. So the most important thing to learn is how to learn on your own. And I'd like to expand on that sentiment a little bit further by taking a quote from one of my favorite poets, Cleo Wade. She says, "Our wisdom does not just come from what we learn, it also comes from what we unlearn." So things that we thought were true, we have to be open to realizing that it might not be the whole truth and we have more to learn. So my first exposure to sleep dentistry, or airway dentistry, was sleep dentistry, specifically fabricating mandibular advancement devices. And I learned the hard way, unfortunately, that while they can have a positive impact on some patients, they're often a Band-Aid solution. These patients would come in, I'd fit them for a device, they'd have amazing results, feel much better, and then I wouldn't see them again. I wouldn't see them until there was a problem with the device or until the device was lost, and now they are dependent on that device in order to feel good. And it always bummed me out that that was something limiting my ability to help them, was that they had to rely on this device to feel better. And a lot of these patients that are being referred for mandibular advancement devices are non-obese, have true craniofacial problems. Sometimes it's a retromathic mandible, oftentimes it's a deficient maxilla. They have high arch palates, and all of those things are the highest risk factors for sleep disordered breathing. And it's really easy for us to have, as a society, to miss that to ignore symptoms or dismiss symptoms and signs of that because snoring is so socially acceptable. It's even comical. You look at the emojis on your smartphone, the sleeping app is of the emoji snoring. So it's so normalized that we're missing a pathologic problem. It's more than a sound in the bedroom, and these patients complain of brain fog, difficulty accessing their full mental capacity. Often they're depressed, have anxiety, other systemic health issues. And they also tend to present with chronic dental needs. We're filling abfraction or class 5 gingival lesions that continuously fail. We have fractured teeth. We have root canals that fail. We have implants that fail. They start to be on this roller coaster of not being stable. So in 2017, the ADA came out with a statement that acknowledges that we as dentists should be screening for sleep disordered breathing. But the statement alone leaves a lot to be desired. It tells us that we're responsible for screening, but it doesn't discuss or suggest that we have an active role in helping our physician colleagues in treating these patients. They go a little bit deeper in talking about pediatrics. It gets slightly more specific, discussing things that with deficient growth can lead to airway issues down the road. So it suggests that suboptimal growth will continue to be problematic throughout life. The American Academy of Pediatric Dentistry also offers guidelines on screening for obstructive sleep apnea, and they touch a little bit more on the many pieces to this complex puzzle. They talk about tonsillar adenoid hypertrophy, obesity, snoring, and they actually mention tongue positioning, not tongue function, but tongue positioning. So it's getting a little bit closer. I love this cartoon. It represents, the elephant in the cartoon represents obstructive sleep apnea or sleep disordered breathing. And all of the different providers are looking at a different part of the elephant with blinders on. So we all have different perspectives to a common problem. And everyone at this conference knows there isn't one approach to the problem of sleep disordered breathing. However, there are common causes. We need to chase the why if we want to be able to truly fix the problem. Without knowing the why, we're only really limited to continuing to offer Band-Aid solutions. So the next several slides are photos of actual patients of mine, and they all have several things in common. They're all non-obese, have high arched palates, narrow dental arches, either retrognathic mandibles and or protruded maxillas, and they all have obstructive sleep apnea. They all have a diagnosis of obstructive sleep apnea, and they all have tongue ties. We often will see masked cross bites, where the lower teeth are lingually inclined to fit inside a narrow upper arch. Patients will have long, narrow faces and often have a forward head posture. Dentally, we see crowding, abfractions or non-carious cervical lesions. We start seeing this pattern over and over again. So why should we care about early intervention besides the obvious dental problems associated with small mouths? A huge study that really changed the American Academy of Pediatrics was a large population-based longitudinal study run by Karen Bonnick in 2012. It followed children from birth to age 7, and it included 11,000 kids. So it's a massive amount of observation. And the biggest takeaways were that the younger the kids were when they were diagnosed with sleep disordered breathing, the worse the outcomes. And the worse the sleep disordered breathing, the greater the suffering. So sleep disordered breathing in infancy and early childhood increases the likelihood of problematic behavior in later childhood. Young children who snore or breathe through their mouths while sleeping have an increased likelihood of future problematic behaviors. Tongue dysfunction not only contributes to the suboptimal growth of the maxilla and craniofacial respiratory complex, and is a risk factor for long-term risk factor for sleep disordered breathing, but the reverse of that is true as well. Tongue function can combat sleep disordered breathing if we optimize it. So the earlier we can identify that, the more ability we have to help. Oops, moving a little bit too fast. Let me jump back one. So in 2019, Dr. Christian Guilleminault had a paper published that talked about abnormal breathing beginning much, much earlier than the onset of obstructive sleep apnea. So his point was that the opportunity to intervene is far earlier than waiting for the development of obstructive sleep apnea, which is an end-stage disease. So abnormal breathing is a smoke before we see the fire. So don't dismiss it or overlook it. Damage occurs neurologically and systemically and dentally long before they're sick enough to have a diagnosis of obstructive sleep apnea. So if screenings and clinical findings suggest dysfunctional breathing, evaluate for tongue dysfunction and for restricted oral tissues, because that's likely the cause of that growth trajectory. Risk factors can be determined as early as in utero and in infancy. We can look for retrognathic mandibles, and we can look for small mouths. We can observe for difficulty breastfeeding. So we have the ability to recognize these issues very early in life. So as far as the timeline and management and when do we intervene, I always say intervene when we know that there's a problem. An intervention doesn't necessarily have to be major intervention or invasive. It's well accepted in our field that noxious habits like thumb sucking, as well as cross bites, should be addressed as early as possible. But what about tongue function? What if we got a little bit further down that rabbit hole and noticed the dysfunction that is causing the crossbite and actually even causing high risk for noxious habits such as such as thumb sucking? So we've learned that if there's tongue dysfunction or tongue mobility issues, the tongue can't rest on the roof of the mouth appropriately, stimulating the parasympathetic nervous system to self-soothe. So reflexively, an infant, even in utero, will put their thumb in their mouth to stimulate that spot on the palate to go into self-soothing or parasympathetic response. Eventually, that reflex becomes habitual. But if we start to see those cute behaviors and wonder why they're doing it, we might be able to identify something that's easy to change when caught early. So it's possible to expand the primary dentition. And there's also such things as preform appliances like Healthy Start and MyoBrace. There's myofunctional therapy. There's feeding therapy. There's lots of things that we can do rather than just waiting for things to be bad enough for us to treat traditionally, fixing crowding teeth with appliances in adolescence. So we see clues of it every single day. We see low tongue posture, and we know that low tongue posture can drive mandibular growth, causing the tendency for a class 3 molar relationship. So if the mandible is growing forward because of the low tongue posture, what that really means is that the maxilla is not growing forward. So often we look at a class 3 molar relationship as a mandibular problem, but really it's a maxillary deficiency. The recurrent theme in all of these findings is tongue function. The hard palate, if the hard palate is narrow and vaulted, the soft tissue that's behind the roof of the mouth, behind the hard palate, isn't stretched transversely, and so it drapes, it's elongated, and it drapes into the oropharynx, and that acts as a point of constriction and an issue. So all of our soft tissue, our tonsils, our tongue, and our soft palate are trapped behind wherever our jaw grows. So everything's dependent on the position of the jaws. And when a narrow maxilla, if there's a narrow maxilla, it puts the nasopharynx at risk for loss of muscle tone and collapsibility. We've touched on this a couple times already, but the patients with sleep disordered breathing have similar orofacial presentation. Long faces, narrow vaulted palates, constricted arches, malocclusion, crowding. And this has been shown in a few studies to be consistent. So let's connect the dots. Tongue tie and narrow palate. Is there a missed opportunity there? And I think there is. The roof of the mouth is the floor of the nose. So I keep saying if the tongue's not in the roof of the mouth, it doesn't drive forward lateral growth of the maxilla. But that means it's also not promoting growth of the floor of the nose. A broad roof of the mouth provides adequate tongue space for the tongue to posture properly up and out of the oral pharynx. And a broad roof of the mouth is a broad floor of the nose, which allows enough space for the nasal septum to stand up and decrease the risk of nasal constriction. There was a study done in 2019 where patients that had persistent nasal obstruction following nasal surgery was associated with narrow high arched palates. So the takeaway from that was if these patients had persistent nasal issues after surgery, they would benefit from maxillary expansion in order to decrease upper airway collapsibility and decrease respiratory effort. In dental school, we were taught, or at least I was taught, that it's not possible to expand the maxilla in adulthood due to a tortuous suture. So after adolescence, expanding the maxilla was no longer possible, or that's what we thought. But with the addition of mini implants or TADs, and sometimes surgical facilitation, expansion is now quite accessible and predictable despite age. So there's maxillary skeletal expansion, or MARPE, mini implant assisted rapid palatal expansion. And there's also distraction osteogenesis maxillary expansion. Before that, we only had orthodontic surgery and SARPE in order to create more space. So distraction osteogenesis maxillary expansion is basically a Lefort 1 osteotomy, which releases the resistance to facilitate opening at the zygomatic buttress. Therefore, it minimizes the forces necessary to open the palatal suture. This is very supported in the literature thanks to the Stanford Airway team, including Drs. Guilleminault, Audrey Yoon, and Stanley Liu. They've been very progressive at advancing the studies on this and do this type of procedures at Stanford, but now it's becoming more and more common in private practice. So their study about dome shows that an increased floor of the nose provides greater nasal volume, and that decreases resistance to nasal breathing, requiring less effort. So the bigger the nose, the easier it is to breathe, the less collapsible the airway is. So the bigger the nose, the less collapsible the pharynx. A secondary benefit to that is improved tongue posture. So a tongue that previously sat low in the mouth, causing the small mouth, now has the space to come up and into the oral cavity and out of the oral pharynx. Oftentimes, the majority of the times, the tongue needs to be taught through therapy how to occupy that new space. We'll touch on myofunctional therapy in a little bit. So in these two images, we see that it's the same patient on the left, or in image A, pre-dome or pre-distraction osteogenesis maxillary expansion. The tongue is low in the oral cavity, not engaging with the roof of the mouth. And by sitting low, it sits back into the pharynx. After surgery, the tongue now sits up and forward on the palate, and the base of the tongue comes out of the airway. So the takeaway from this is that maxillary expansion should be considered as an adjunctive therapy in children that have persistent sleep disordered breathing and a narrow palate. We previously only talked about adenoids and tonsillectomies, but maxillary expansion should be considered as a first line of treatment to create more oral volume and nasal volume. So my colleague, Shireen Lim, shared a quote during a presentation recently that she heard from Dr. Guilleminault at the AACP conference in 2014. He said, if you're doing palate expansion, you're too late. So while we've had many advancements in treatment options to correct the skeletal anomalies and problematic growth patterns, If we could intervene sooner and recognize these issues sooner, we may not even need these interventions. So we know the old phrase that form follows function. We know that form causes high risk factors. So let's talk about function. What is a tongue tie? The International Affiliation of Tongue Tie Professionals defines the lingual frenulum or frenum as a remnant of tissue in the midline between the undersurface of the tongue and the floor of the mouth. A frenum is a normal anatomic structure, but if it interferes with function because it's too short or restricted, it's called ankyloglossia or tongue tie. One of the main reasons that optimal tongue function is impeded is due to restricted fascia or short lingual frenum. So while tongue ties may seem like a new topic, they're not. They've been around for a really long time. There are papers that talk about midwives having a sharp fingernail in order to intervene with a short frenum at birth to facilitate feeding in newborns. The paradigm shift is in understanding where the restriction is. A tongue tie was previously thought to be a tongue to tip, a fascia that would go to the tip of the tongue, holding it down on the floor of the mouth. But we now know that there's submucosal restriction. Sometimes that's referred to as a posterior tongue tie. It just means that the restricted fascia is farther back posteriorly in the tongue. So one of the biggest hurdles for discussing and recognizing this abnormality in anatomy and its role in driving growth is lack of standardization for what a tongue tie actually is and how to classify it. There's lots of confusion across disciplines and fields as to what it is, when it's appropriate to intervene. I've often heard qualifiers such as a little tongue tied or slightly tied, but I think a better way of considering the frenum is it restrictive or not? Does it require compensatory workarounds to function appropriately? A huge advancement is the standardization and quantifying of tongue ties. So there have been different classification methods in the past, but it was never really standardized. And there was a lot of room for subjectivity in the measurements, which caused a lot of confusion. The tongue range of motion ratio was established by Dr. Yoon and Dr. Zaghi and their colleagues, and it quantifies the restriction based on range of motion in comparison to maximum opening of the mouth. So you can measure the range of motion from the tip of the tongue to the incisive papilla, and you can measure it from lingual palatal suction. So this image shows that at maximum opening, there's different abilities to elevate the tongue upward with the tip of the tongue and also in suction. My mentor, Dr. Zaghi, I mentioned him earlier, has dedicated a huge part of his career to advancing research. So this study was very impactful and has become very helpful in trying to standardize screening protocols. So what can we do? What should we do? And when can we do it? Or when should we do it? The human fetus shows swallowing movements as early as week 11 of gestation. So you think about how much pressure and how early on the tongue is impacting the shape of the palate. It's pretty profound. Once born, a person swallows, and into childhood and adulthood, a person swallows 500 to 1,000 times per day. So that consistent function is going to shape the form. Incorrect swallowing can contribute to a number of problems. Also, additively to that, resting tongue posture has an effect as well. So not only activating the roof of the mouth with the swallowing motion, if the tongue doesn't naturally rest on the roof of the mouth and sits low in the mouth, the palate's going to be more narrow. So what impedes optimal function? What's normal? What's restricted? Very quickly, we learn to adapt and compensate in order to survive. We see that as early as day one of life. Babies can use their alveolar ridges to express milk from the breast rather than their tongue. We will mouth breathe if we can't breathe through our nose. So we learn how to compensate really quickly. Another common compensation is leaning into a forward head posture in order to open the airway and decrease a narrowing or constriction of the airway. We clench to stabilize our airway and prevent collapsibility. We grind and posture forward to open the airway. These compensations allow us to survive, but they don't come without pathology or symptoms. So these are some visual clues of what's normal versus abnormal when looking for tongue dysfunction. The picture on the left shows what's called an Eiffel Tower presentation. The insertion of the frenum is into the alveolar ridge rather than the floor of the mouth. Also, the insertion of the superior part of the frenum impacts the ability for the tongue to elevate. The tip of the tongue in a tongue that's restricted is often heart-shaped or V-shaped. Not always, but many times it is, depending on where the insertion of the frenum is. And many times I've heard patients and other colleagues say, well, they're not tongue-tied, or I'm not tongue-tied because I can stick my tongue out. And it really doesn't have anything to do with sticking the tongue out or extending the tongue. It's all about the ability to elevate it. And then these pictures, especially the ones on the left and the right, show that in extension, the tip actually drops down. And you can imagine that to try to lift the tongue up would be very difficult, if not impossible, because of that restricted tissue. So a couple more common presentations. Eiffel Tower presentations, you can see how the pull on the alveolar ridge looks just like the Eiffel Tower. You can see the heart shape or the V-shaped tip. And you can see how the edges of the tongue curl up, as opposed to the one on the far left, which is normal extension, or elevation. And then this slide just shows us some different insertion points. Sometimes they're really obvious, like on the far right, where the frenum is to the tip of the tongue, but more often they're a little bit more subtle, where it inserts to the mid-ventral or posterior ventral part of the tongue. And then we look to see if the inferior part of the frenum attaches to the floor of the mouth or the alveolar ridge. I mentioned forward head posture earlier. In addition to the craniofacial abnormalities I mentioned previously, forward head posture is often a symptom of ankyloglossia. This is a daytime compensation, and it's often lost at night when the airway is constricted by gravity and sleep position. The other reason we'll often see forward head postures with ankyloglossia is that fascia is quite organized. It's not haphazard in the body. The deep line of anterior fascia starts at the tip of our tongue. It goes down our chest, down our mediastinum, it connects to our diaphragm. It goes down to our hips. At that point, it crosses across our body and goes down toward the tips of our toes. That's one piece of fascia. And so you can imagine if it's restricted or tight at the very top, it's going to pull everything up and forward. In fact, during tongue tie surgeries, sometimes I'll see patients' shoulders relax down, and they'll say that for the first time they feel as though they got a full breath because their diaphragm has different mobility. While we're addressing orofacial myofunctional disorders in adults, and that can be beneficial in adulthood, the sooner the problem is addressed, the better. It's a common theme in this presentation. In infancy and childhood, we have a significant opportunity to not only alter growth. Nisbet's research shows that if caught early enough, there can be avoidance of severe autonomic dysfunction and there can be avoidance of severe autonomic dysfunction that would come with missed sleep disordered breathing and altered breathing into adulthood. Many significant growth and development milestones occur during our first 18 months of life. So we are just an absolute hotbed of growth when we're babies in early childhood. In fact, 60% of a child's facial growth is completed by age 6, and 90% of the facial growth is done by age 12. As children grow, proper breathing is essential to their health and development. And we have tools to correct improper growth, but what about facilitating proper growth with the function earlier? So oftentimes the first time we're thinking about sending kids to see the orthodontist is at age 7. 60% of the growth is done by age 6. So intervening and redirecting even earlier is hugely important. So we keep talking about how anatomy is the key to all of this. And what drives anatomy? We know that the tongue function drives that anatomy. So if we see a nice broad U-shaped dental arch, we know that the tongue is resting on the palate as it should. If the arch is V-shaped or narrow, the tongue is low in the mouth. These depictions are from my friend Shireen, and I think do a really good job of showing exactly what's happening with the tongue acting as the scaffolding for the teeth or not. Optimal breastfeeding depends on optimal tongue function, and this is a huge passion and part of my practice. If we can identify restricted oral tissue in infancy and facilitate breastfeeding, we're going to have huge impact on the growth of the jaws. I mentioned that babies can compensate and express milk by chomping with their alveolar ridges, but that is not going to lead towards success. It often comes with symptoms of aerophagia or gassiness and colic in the baby and pain for the mom, and also alters the growth of the mouth. So breastfeeding optimally initiates a forward and counterclockwise growth pattern, and it has totally different physics on the skeleton than bottle feeding does. Bottle feeding is much more passive and doesn't require much jaw compression. And we don't see as much jaw work, so we don't see development of the masseter muscles. And bottle nipples or artificial nipples don't spread and shape the palate the same way the tongue can compress the breast to do. Another image from Shireen that shows the tongue position while breastfeeding. On top of the tongue right here is the breast compressed against the palate, and this is a depiction of the tongue posturing with a nipple, where the tongue cannot compress the nipple to the roof of the mouth, and we have to rely, or the baby has to rely on more constriction of the cheek muscles to suck, causing compression from that perspective as well. So while breastfeeding is not available to all families and all babies, it's important to understand why it's so important, so we know what we're looking for and know how and when to intervene and correct that jaw growth as quickly as possible. And like I said before, that can be done with feeding therapy specialists, preform appliances. There's something called a myomunchie that helps develop those muscles when natural function isn't available. After breastfeeding, baby-led weaning continues encouraging those growth patterns. So if a baby's given a high diet of strictly purees and doesn't have to use any musculature to chew, we're going to see low tonicity in their facial muscles and start to see a collapse of the dental arches. Kids with tongue ties tend to be picky eaters because they choose foods that are easy to swallow, such as softer foods, and that continues that suboptimal growth pattern that passive feeding promotes. We're also very quickly moving in the society, and in convenience, we've come up with ways to offer nutrition on the fly. And so one of the things that's very common in early childhood is food in pouches. And a pouch from time to time, of course, is not going to be problematic, but if that's a source of regular nutrition, that consistent sucking motion will actually alter the jaw growth or the jaw shape. So I've mentioned therapy a couple times. What is myofunctional therapy? Once we've passed the hurdle of recognition and diagnosis, we now have to understand that simply relieving the restriction is not enough to restore function. A lot of well-meaning providers do what I call a clip and go. They clip the visible anterior portion of the restricted tissue, but they don't account for the dysfunctional pattern, and we won't get good outcomes because we're missing the why. So myofunctional therapy helps identify compensations and dysfunctional patterns, and it retrains proper function. The 4 major goals of myofunctional therapy are nasal breathing, exclusive nasal breathing outside of speaking and exertion, lip seal all day and night, passive lip seal, I should say, oftentimes when there's restricted tissue, we'll see lip seal with mentalis strain, or a lot of muscles having to fire to get those lips to close. Correct tongue posture, resting on the roof of the mouth, and a correct swallowing pattern. When we swallow, we shouldn't see any movement in the face. It should all be internal. But yeah, with patients that have tongue dysfunctions and facial muscle dysfunction, we'll see a lot of pursing of the lips like that, or squeezing of the mentalis muscle to get the food back, as opposed to relying on the tongue's natural movement to swallow. So I think that myofunctional therapy is the treatment. Sometimes a functional frenuloplasty or tongue tie release or a frenectomy is necessary to further progress the therapeutic outcomes because the restricted tissue is preventing the appropriate function. So that's a really important distinction. The tongue tie surgery is not the treatment. It is done in order to facilitate the ability to complete myofunctional therapy. So myofunctional therapy is the treatment. And it's really interesting to have watched literature progress over the last decade or so to come to that conclusion. Let me share that with you guys. So more and more research is emerging to show the connection and efficacy of myofunctional therapy as a treatment modality for obstructive sleep apnea. In 2013, Umino and his peers showed that myofunctional therapy is important in preventing recurrence of obstructive sleep apnea in children following adenotonsillectomy and or orthodontia. In 2015, Camacho's systemic review and meta-analysis showed that myofunctional therapy reduced AHI by 50% in adults and 62% in children. So myofunctional therapy alone was able to make major improvements on AHI. So using that as a combination therapy with a mandibular advancement device, with tonsil and adenoid removal, with expansion, with CPAP, means that the outcome for these patients is going to be greatly enhanced. There's research that shows that there is a correlation between the short lingual frenum and obstructive sleep apnea. And they started in 2015, they started to suggest that myofunctional therapy may be needed after the frenectomy surgery to restore normal nasal breathing. There have been future studies or studies since then that show that that actually is quite true and necessary. So in 2016, there was another study focusing on myofunctional therapy, showing that it actually favors the adherence to CPAP usage. So CPAP compliance goes up when doing myofunctional therapy in combination with it. So in children with residual apnea, the myofunctional therapy decreased the AHI, just like in that previous study. It increased the overall oxygen saturation, and it improved the oral facial myofunctional status, getting rid of those disorders. In 2017, there was a really important class level 3 evidence cross-sectional cohort study completed. And the question was, could altered tongue mobility affect the development of the maxillary arch? So we anecdotally can conclude that or see that, but the study was done to show that that hypothesis is indeed correct. A big study in 2019 studied 348 cases showing the efficacy of combination therapy between tongue tie release and myofunctional therapy. There was a 91% satisfaction rate across patients, and 87% of them had an improvement in quality of life from either a decrease in mouth breathing and or snoring, decrease in clenching, and less myofascial tension. So here's a quick summary of that literature review. All the way back to 1972 when OSA was discovered, and then, you know, the problem, the what, continued to become expanded upon. And then that what slowly turned into why, which led us to more structure. And then that why continued to lead us to function and how that function impacts the structure that causes the what. So don't they grow out of it? Many of us have heard the phrase, they'll grow out of it, when presented with a child with signs of sleep disordered breathing. However, it's a continuum. It usually gets progressively worse, and studies show that over and over again. Symptoms and compensations may change, but it continues to become more and more problematic, with obstructive sleep apnea being an end-stage disease. So study after study shows that it gets worse. A really interesting study is the CHAT study, which is the Childhood Adenoid Tonsillectomy Trial. That's where the CHAT acronym comes from. It's a study that's often used as evidence to argue for watchful waiting and not intervening. But look at what it's actually saying. So in the study, 21% of kids had recalcitrant obstructive sleep apnea 7 months after tonsil and adenoid surgery, but 79% didn't. So 79% of kids got better after tonsil surgery. 46% of the kids with watchful waiting got better too. The problem is we don't know which half is going to get better. And it's a pretty risky chance to take when we know how dire the outcome of obstructive sleep apnea is in childhood as far as neurologic development. So I think that's a pretty profound thing to consider when we're trying to decide, is it worth doing something? And I think, yes, if we see that there is an issue, it is worth doing something. It might actually be better stated if we say that they will grow into it rather than they'll grow out of it. Things get worse. Neurologic development is huge before age 3. So much is happening as we're growing and developing in those first couple of years of life. And so, yes, they may grow out of it and survive without intervention, but they will be a different kid.
John, you've done way more than...
Rizal's study in 2013 showed that sleep disturbances in children can lead to alterations in the autonomic nervous system. And these alterations facilitate occurrence of metabolic and cardiovascular morbidities. So it becomes a compounding systemic risk. Trossman in 2015 showed that not only did children who underwent watchful waiting not resolve their OSA, but the average AHI of those kids got worse. So that supports what was found in the CHAT study. And then in 2015, there was a study that showed that impairment of nasal breathing with increased nasal resistance has a well-documented negative impact on early childhood maxillomandibular development. So repetition of the same message over and over again. So I'm going to end this by challenging all of you to keep asking why. We know we have solutions to help with our adult patients. But if we can recognize it in babies and children, our impact could be so much greater. And there are always signs or smoke signals that we could see if we're looking for them. The sooner the dysfunction is recognized, the sooner it can be corrected. So this little baby is shown on day 1 of birth with low tongue posture and open mouth resting posture. The second picture is this baby at 6 months old. The third is at age 2. And the last picture on the right, she's 6 and she has a diagnosis of severe sleep apnea. And retrospectively looking back, we could have seen early signs of that on day 1. I'm extremely passionate and excited about this topic. I'm happy to talk about it forever and always. If you've got questions, comments, suggestions, anything like that, please don't hesitate to reach out to me. My email address and my social media contact and website are on the lower right of the screen. Thank you so very much for your time and good luck with your journey.
Thank you very much, Maggie. Are you there?
I'm here.
Okay, just a great topic and great presentation. Thank you so much. It's Friday afternoon. I'm not going to take too much of your time, but you know, as you were speaking, it's a long story why we didn't have more people here today, but it almost doubled after you started your presentation. So thank you. I run across this a lot in my orofacial pain and sleep practice, and most recently, I mentioned it earlier. I had a very young baby, an infant, you know, a couple months old, and and she wasn't nursing, and she looked like she was having pain when she was eating, so the parents brought the infant in. And long story short, she was diagnosed with severe apnea, and she was desatting to 77%, and most notably, she had what I thought was a pretty obvious tongue tie. And I asked the mother, why was this not corrected? And she said the ENT didn't think it was necessary. And so I disagreed. And long story short, we arranged for her ENT to revisit her because that's how she wanted it. I was going to try to get her down to you. But anyway, it made such a subjective difference in this kid. But she was diagnosed with Pierre-Robin sequence. So if someone's got sleep apnea and you fix a tongue tie, and you're not certain if there's apnea or not, unlike this child, do you almost always, if they're showing some signs or symptoms, do you recommend a sleep study?
Do I personally?
Yes. Or professionally, would you?
No, I work with an ENT. He works in my office with me. And we share a lot of cases because we share anatomy. And so we think we know that we both need each other so much. And the problem with the sleep study, and the reason I was so fast to say no, is there's so many obstacles to get it. And they're screening only for the sickest kids. They're only screening for kids with obstructive sleep apnea and sleep disordered breathing and arousals and a hyperactive sympathetic system is happening below the threshold of the sleep studies. And I don't care about needing a diagnosis to be able to help these kids objectively grow better and feel better. So while I think there's obviously a place in them, I think it's missing too many sick patients.
So if you have a child who has signs of high sympathetic tone, anxious, they're not irritable bowels, etc., not sleeping well, despite not having a sleep, you're gonna assume there's a sleep-related breathing problem, and you're gonna go right to myofunctional therapy after the tongue tie, regardless.
So I will do sleep screenings.
If you have to go, by the way, you're in a meeting. I know that if you got to run, I'll get questions to you, and that's okay.
No, I don't mind at all. I love multitasking. I will do a sleep screening to look for objective data to look for risk. And if that sleep screening comes back and it shows that they are high risk, absolutely. We want to involve their pediatrician. We want to involve a sleep physician because it's so multifactorial. It's not necessarily just me. But if they show all of those signs and I see anatomic problems, why wouldn't I intervene on those anatomic issues? I don't understand why I would hold back on doing something that I know is better for them in a lot of different dimensions than just sleep. And I know that it probably will help. So I really talk a lot about form and function and growth of the face, even though I know that coincidentally or along for the ride is going to be bettering of other symptoms and systems.
One question, and then if you have to go, you mentioned
I'm
health.
great.
Okay, you mentioned Healthy Start. Anonymous attendee says, thank you much for a great presentation. And I agree. You mentioned Healthy Start and MyoBrace as a good interventive option. Could you elaborate a little bit on these when you use them, and in which you most recommend? MyoBrace versus Healthy Start.
I think they both have pros and I think they both have cons. And I think that the problem with a one-size-fits-all thought process for any product, including those two in particular, but anything that's out there, and there's so many other ones out there as well, is that it's not going to work for everybody. So the more I have access to, the more tools I have in my tool belt. I like Healthy Start because it has a really low profile. It's very small, and so it's not as obstructive, so it's easier to sleep in for some patients. The Myo Munchie is great because it causes a chewing. It instinctually causes chewing, which can help with salivary flow and muscular development. So I think that they both have their place, and I don't think one replaces the other. And there's, like I said, there's plenty of other ones out there that I don't even know about.
If I have a pediatric dentist who does MyoBrace and mentions that he or she does myofunctional therapy, are there credentials that I should look for that show that office has had a minimum of training where I can be comfortable in turning my patients over to him or her?
That is a hot topic right now, and there's no credentialing body for myofunctional therapy. I think that we're going to be moving close to it. And I think that the people that are in the heart of it and have been doing myofunctional therapy the longest agree that there needs to be some sort of regulation in order to help exactly this issue. But I think that the best way to screen practitioners right now is ask questions. Tell me about your therapy program. How often do you see them? What are you looking for? How do you know when a patient is ready to graduate? If they're trying to fit a patient into a box or give a list of exercises, that's a red flag to me, because there isn't a list of exercises that patients can Google and find videos to try. But if they're not being assessed with somebody that understands compensatory dysfunction, those exercises might not be very helpful. So it's a really long-winded answer to say there isn't necessarily one specific training body out there. There's several. But I think asking the questions of the therapist or the office of how they're implementing the therapy in their office tells a lot more.
Okay. Can I ask one more question? Anybody
Ask me
else?
as many as you want. I can talk about this stuff all day.
All right. Well, you've been so nice to do this. I have a lot of patients sending me for sleep apnea, but they're more adultish than childish. And so many have tongue ties and they have severe apnea. And so they're already asking a lot of dental sleep medicine when it's severe, especially non-positional. And if that was your dad coming to me and he had a tongue tie and severe apnea and was refusing to continue with CPAP, would you take care of the tongue tie? Because I tend to refer locally these adults to an oral surgeon. I just don't know if I should be aggressive with that, or what would you do if it was your family coming in with tongue ties and they have apnea?
I'm going to sound like a broken record. It really comes down to function. It really comes down to how much it's inhibiting. I think myofunctional therapy is it should be part of every single treatment plan, just because it addresses the position of the tongue. It helps with lip seal. It helps promote nasal breathing. Now, if there's anything inhibiting any of those goals, nasal obstruction, a really constricted base, or a tongue tie, then yes, I definitely think that those things should be addressed.
Would you do a tongue tie on these people?
Oh yeah. I mean, if they have gone through myofunctional therapy and
No,
they
if they
have
have
adequate,
if they have not gone through
no,
myofunctional therapy.
I don't do tongue tie releases without myofunctional therapy.
Oh, OMT first or concurrently or always together?
Always together. So I will do the assessment, or they'll be referred to me from, if they're being self-referred or referred to me by a provider that recognizes the anatomy, I then refer to myofunctional therapy, and they start with the therapist until they can't progress the therapy any further because of the restriction. Then I do my surgery as a way to facilitate the therapy, but I truly believe that the therapy is the treatment.
Would the therapist have a good idea if that patient's being responsive and really and doing well with the
So what they're
OMT?
looking for certain parameters to see if they are compensating less and they're able to start to utilize muscles more appropriately. And they can see it's not rocket science. It takes a lot of consistency and commitment, but it's something that they can see changes fairly quickly. So for a patient that is ready to have frenuloplasty, usually they need about 4 to 6 weeks preoperatively of myofunctional therapy. Now, everybody's different. Some might have ingrained muscle memory that's harder to unlearn. Others might be too busy to commit to the exercises, but usually it's a short phase of treatment.
If it's an adult and I'm not watching him or her breastfeed, obviously, how do I know if how does an adult compensate that would be a red flag that he or she is not managing or doing their OMT or being effective?
If they have any odd swallow patterns,
okay.
they have a pursing of their lips or mentalis strain, if they have open mouth posture, any tension in their facial muscles or their neck muscles, any altered growth, they would benefit from a myofunctional evaluation.
So there are objective parameters then whereby that person could say he or she's being successful or not, and it's ergo a tongue tie is indicated or not indicated. Excellent. Wow. I've got so many.
And for the adult, one of the things that's actually easier about adults and big kids is that while having somebody in person is always the best option, because this is something that is gaining traction and there aren't enough providers, someday I hope everyone will have a primary care doctor, a dentist, a myofunctional therapist, a therapist. But right now there's not enough of them. So you can actually get a lot done virtually. And after the year and a half that we've had with COVID, people are quite comfortable in a Zoom setting. So a lot of this therapy can be done virtually.
Okay. Wow. Oh, virtual. Wow. That's awesome. Okay. Let's see if there are any other questions, and I'm gonna, I think we're done, and so I'm gonna let you have your freedom back and enjoy that meeting. You traveled all that
Going right
way
back
and
into the lectures.
well, but I'm going to let you go, and I really appreciate your participation and getting way out of your way to take care of your.
Oh, so happy to be involved. And if any of the people watching, or if they end up watching the recording, are interested or have follow-up questions, like I said, I talk about this stuff all day, every day.
And they can email me, and I will email you, and
Perfect.
get you connected up. All right.
Perfect. That sounds great.
Thanks, Doc.
Have
Really
a great day,
appreciate it.
everybody.